Credit to my lecturer, Madam Rafidah binti Supar. My name is Noor Farhana binti Maslaidan, student ID 224452248. This is my video presentation for individual assessment for code MRD4 for radiographic image evaluation of AP cervical. This is the list of content and the presentation. Jansbon. It consists of radiographic anatomy, positioning criteria, exposure factors, and radiographic image evaluation using Paceman methods. Paceman is the method that used to critique the radiograph, whether to accept or reject the radiograph. It consists of important point to be looked at. P is for projection or positioning. A is for alignment. C is for collimation. E is for exposure factors. M is for the marker. A is for the aesthetics of film size. Lastly, N is for the name and patient. I, D. For the next, this is an anatomical structure for the cervical spine. It consists of the full region of vertebra body of C1, C7, the spinous processes, laminae, present of both clavicle, transverse process, and pedicles can be seen. Radiographic anatomy of the C1 vertebra, also known as the atlas, is the first cervical vertebra of the spine, and plays a crucial role in supporting the skull. The key features of C1 is the ring-shaped bone, with no vertebra body or spinous process, composed of an anterior arch, posterior arch, and two lateral masses. Supports the skull by articulating with the occipital condyles of the head, forming the atlanto-occipital joint. C1 function is to provide stability and mobility to the head. Protects the upper spinal cord and vertebral arteries. Next is the structural features of C2, also called as axis. Wado? It's the second cervical vertebra, and has more complex structure than C1. The key distinguished feature is the odontoid process, or known as dens. The axis is projected upward from the anterior body. Et zone acts as a pivot for rotation of the atlas and the skull. Moving to the next is the structural of cervical vertebra, from the C3 to the C7. More common tamakegi. It is structurally uniform. More common tamagi. The main components consist of the vertebral body, the posterior neural arch including with the right and left of the pedicles and laminae. Together the body and the neural arch enclose the spinal cord. Common accretive laminae. Additional features is the articular processes that located at the junction of the pedicles and laminae, the transverse processes that extend laterally from each pedicles, and the spinous processes that projected posteriorly from the midline at the junction of the laminae. Moving to the next is the criteria of positioning. For AP cervical, patient placed in supine or erect position with their head against the IR. Patient mid-sagittal plane is aligned with the center of the IR and perpendicular to it. Both shoulders should be equal distance from the IR. They should be relaxed and depressed as much as possible. Chin is elevated sufficiently to prevent superimposition of the mandible over C1, C2 region. Extra credit. In trauma situations, if the patient has a cervical collar in place or suspected injury, the chin should not be manipulated. Instead, the X-ray tube must be angled to adjust to compensate for the lack of chin extension. Next, ensure patient head in straight position without rotation or tilting. Angle the X-ray tube 15 degrees cephalad. The incentering point should be at the level of C4, or just below the thyroid cartilage, or known as Adam's apple. The collimation for superior should include the base of the skull and mandible. The lateral border collimation include the soft tissue and transverse recess of the revival vertebra. Moving to the next, this is example of incorrect positioning. There appears to be rotation of the cervical spine. The spinous processes are not midline. The mandible is superimposing the upper cervical, especially the C1, C2. Shoulder not sufficiently depressed. For improvement, ensure patient head is straight and aligned with the MSP perpendicular to the IR. Ask patient to elevate the chin slightly to move the mandible away, and instruct the patient to relax and depress down the shoulders. Moving on to the exposure factors criteria. While we evaluate the contrast, KVP, the density, and the MAs of the radiograph. For AP cervical radiograph, to evaluate the contrast, we see the thin structure, which is BCO of spinous process, and the thick structure, which is BCO of vertebrae body. To evaluate the density, we see the BTP of thin structure, which is spinous process, and the BTP of thick structure, which is vertebra body. For example of this radiograph, we can see the BCO of thin structure, which is spinous process, and the BCO of thick structure, which is vertebra body. This is indicate that the KVP used is adequate for penetration and radiographic contrast. We also can see the BTP of thin structure, which is spinous process, and the BTP of thick structure, which is vertebra body. This means the MAs used is adequate for details and density. This means both the KVP and MAs used is adequate, so no improvement need for the exposure factors. There are also other scenario of exposure criteria, where the radiograph can be overexposure, underexposure, or overpenetrated. For this radiograph, while evaluating the density of the radiograph, the BTP of thin structure, which is spinous process, cannot be seen, while the BTP of thick structure, which is vertebra body, can be seen. And this indicates the radiograph is overexposure. This means there are many X-ray photon reaching the IR. So the density is dark, and the bony trabecular pattern of the thin structure cannot be seen clearly. To improve, decrease the MAs by 10%. Next is the underexposure radiograph. By evaluating the density of this radiograph, the BTP of the thin structure, which is spinous process, cannot be seen, and the BTP of thick structure, which is vertebra body, can be seen. This indicate there are less of X-ray photon reaching the IR, and the radiograph are underexposed. To improve, double the MAs by 2. Moving to the another radiograph, by evaluating the contrast of this radiograph, the BCO of thin structure, which is spinous process, cannot be seen, and the BCO of thick structure, which is vertebra body, can be seen. This means the radiograph is overpenetrate, and there is too much of KVP used. The bony cortical outline cannot be seen clearly. To improve it, decrease the KVP by 15%. Now we moving forward to the radiographic image evaluation using the Paceman methods. First is the projection. This is a radiograph of AP projection of the cervical spine. This is cervical because the entire cervical vertebra body are seen in the center of the radiograph. The spinous processes of the vertebra appear as thin linear structure aligned along the midline. The intervertebral disc spaces are clearly visible between vertebral bodies. Partial of the mandible and skull base are visible at the top dot. The clavicles and upper ribs are seen at the lower border of the image, which is typical in an AP cervical view. Next is the positioning. Based on the radiograph, the positioning for this projection is incorrect. By detecting the rotation, the shoulder are elevated to the left side. Due to head slightly rotated to the right side, the mandibular rhymi is not symmetrical. To improve this radiograph, instruct the patient to depress down the shoulder parallel to the IR. Realignment of the head is needed to align the head and vertebrae body center to the radiograph. Next is the alignment. There are 3 components for the alignment, which is the alignment from X-ray tube to the cassette, the alignment from the X-ray tube to the patient, Kakabi, the alignment of the cassette to the patient. Based on the radiograph, the alignment from the X-ray tube to the cassette cannot be determined because there is no evidence of foreborder of collimation. For the X-ray tube to the patient, also cannot be determined because there is no evidence of foreborders of collimation. Next, for the alignment between cassette and the patient is incorrect because the distance between the edges of the film to central structure is at C5. The centering point for this radiograph cannot be determined. The standard centering point should be at the level of C4. Moving on to the collimation. The collimation should be done to all 4 borders of collimation. Dussen. At the superior border, structure that should be included is from the base of the skull. At the lateral border, structure that should be included is soft tissue of the neck on the both sides. At the inferior border, structure that should be included is at least until the level of T2 vertebra. There is no evidence of radiation protection apparatus is seen on the radiograph. Part is the exposure factors. Based on the radiograph shown, by evaluating the contrast, the BCO of the thin structure, which is spinous process, can be seen, and the BCO of thick structure, which is vertebra bodies, can be seen. By evaluating the density, the BTP of thin structure, which is spinous processes, can be seen, and the BTP of thick structure, which is vertebra bodies, can be seen. The KVP used is adequate for penetration and radiographic contrast, and the MAs used is adequate for details and density, so both KVP and the MAs must be maintained. Next is the marker. Based on the radiograph, there is an evidence of anatomical marker shown in the radiograph. Correctly placed on the left lateral side of the body, and placed appropriately, not superimposed with any region of interest. Next is the aesthetic. The film size used is 24 by 30 centimeters, which is sufficient to demonstrate all the structure of interest. There is a presence of artifact seen in the radiograph. To improve, remove all the jewelry, clothing, or any patches that could obscure the region of interest. Last but not least is the name or patient ID. Based on the radiograph, the patient name, date of examination, place of examination, and the radiographer name are not visualized on the radiograph. After critiquing the radiograph based on the Paceman methods, we come to the conclusion whether to accept or reject the radiograph. The radiograph is unacceptable. This is because there are no evidence of patient name, ID, place of examination, and the date of examination including the radiographer's name is included in the radiograph, and the positioning for this projection is incorrect.